Welcome to Fertility Friday Q&A, where I answer all of your top fertility questions. Hi friends, I am Dr. Natalie Crawford. I'm a board-certified OBGYN and REI. That means I'm a fertility doctor. And every Friday I am answering your top fertility questions that you ask here on YouTube. All you have to do is subscribe to the channel. Thank you. Help me spread my message and knowledge about fertility education. And then go to the community tab and type your question into the question prompt. And I will get to them as we go. This is a great way that we can all learn and know more about our bodies together. So let's dive in. Can you talk about preimplantation genetic screening? It's expensive, not covered by insurance, and I'm wondering if it's worth the cost. There's a second part, but let's do part one first. Okay, preimplantation genetic testing, PGT, previously was called preimplantation genetic screening or PGS. When we talk about this, we're all talking about embryos and IVF. So quick video for a reminder on IVF, go and check it out. What is IVF and understand the process. But this is an optional stage when you have embryos before they get implanted or transferred into your body. What happens is a group of cells is taken from the trophectoderm or the placenta, the outside of the embryo, and then some of those cells are sent off to get a chromosome analysis of the embryo. This is especially helpful as people get older because we have more genetic abnormalities inside our eggs, have a higher chance of genetic abnormality, miscarriage, and just failed cycle. And so identifying those embryos can be really helpful. Here's my take on this. It depends on your goals. You need to have an honest and open discussion with your doctor about your goals because no two people are the same. In general, women who are older have more chromosome abnormalities inside their eggs. So women who are 35 and older need to strongly consider this because you will have fewer embryo transfers. If we're able to identify that normal embryo and put it inside, we will get a higher chance of success. You also have a lower chance of miscarriage. To me, those are beneficial things. Women who are younger may or may not choose to do the process. Reasons why people don't choose to do it is because they're going to get a high number of embryos and they don't need that information. It doesn't change the embryo at all. The embryo is still the same. It's either normal or not. It's all about, does knowing that information change what you do? So if you are planning on saving embryos for a future child, which is one of the nice advantages of IVF, we take eggs out of your body in 1 month. We're able to make them into embryos, put one inside of you, and then others can be saved in the lab until you're ready to use them. Well, if we're relying on those embryos to become babies for you in the future, we need to know that they're normal because we've not achieved our goal of preserving your fertility if we don't know. Because if all of them are abnormal, you might do another cycle right now before you go and get pregnant. So it all depends on your goal. I will say if you're going for more than one child, most of my patients are choosing to do genetic testing because it's going to save them money in the long run. It's a better return on the investment, even though it costs more, because they will do fewer transfers to get to their children by knowing which embryos to choose because they have a higher chance of success. If you have a limited embryo number, or you're just trying to get pregnant with one child, then it may not be necessary. And then there's certainly cases where we are doing IVF and trying to keep costs really low, like a low cost, low complexity IVF, or a fresh transfer. And in those cases, we're not doing genetic testing. So the short answer is, I think it's worth it for the majority of people if you need to grow your family more than one time, or if you're older, because then you're just gonna have a higher success rate per transfer, and you're gonna know what you really have. I use an example all the time of a friend of mine who was 33 when she went through the process. We got 8 embryos, a great number. Based on her age, at least half, if not more, should have been genetically normal. We did choose to do genetic testing and 1 came back normal, only 1. Now, they had a choice to make. Did they want to go through the process again and try to get more embryos to save for a second child? Because looking in the future, we could foresee that getting a normal embryo tough at 33 probably is going to be really hard as she gets older and has fewer eggs to work with and their quality decreases. Or do we want to transfer that embryo with the understanding that if that pregnancy works, maybe we only have 1 child? And that's actually what they chose. They transferred their 1 embryo. It was embryo 7 on the list of 8. So can you imagine how many failed transfers we would have gone through? How much money we would have spent along the way? So we went into that one, transferred it, and she's a baby, and they've gone through this whole life. That's their child, and they're okay with that. They are okay not going through more cycles, and they really are appreciative knowing that that's their only child versus walking around planet Earth thinking that you have 7 other embryos in storage. You're going to feel all embryo rich, and you may be visioning your family very differently. And instead, this friend of mine has a lot of closure that this is her family, and she's really happy about it. Second part of the question. Also, could you talk about what to expect with a common diagnostic test, HSG, SGH, hysteroscopy, why they're done, what to expect when you're going to have those tests? I had an okay HSG, but then a traumatizingly painful failed SHG, and ultimately had to undergo hysteroscopy. I didn't think the SHG would be that bad because I'd already done 3 cycles of IUI, but it was horrific. First of all, this is not most people's experience, so I don't want to scare anybody, but I think this is really important. These tests are looking at the same but different things, so it kind of depends. HSG is a test where we put dye into the uterus and into the fallopian tubes, and we watch with X-ray, which makes it a 2-dimensional picture of a 3-dimensional object, your body. When we do this, what we're looking for is the outline of the inside of the uterus and the fallopian tubes. It's a great test for the tubes. It's not a great test for the uterus. So typically the point of the HSG is to make sure there's no obvious abnormality inside the uterus, but to see if the fallopian tubes are patent and to make sure that there's no hysterosalpingogram. I have a whole video on tubal disease you may want to check out to learn more about the HSG and hysterosalpingogram. But the other tests are usually pre-IVF evaluation tests. So an SHG, also called an SIS, saline hydrogram, saline infused sonogram, they all mean the same thing. This is where we put water into the uterine cavity to have a much more sensitive test for the inside of the uterus, meaning it's a better test to see in the uterus. We put a speculum in the vagina, a small catheter goes to the cervix. That feels like a pap smear or an IUI. Then a little bit of saline is injected while we watch with a vaginal ultrasound, and we're able to move that around and get a better image of what that uterus looks like to check to see if there's polyps, scar tissue, or anything abnormal inside the uterus. Now, the catheter we use is often a little bit smaller, it's delicate, has to pass through the cervix, so sometimes people have really painful saline sonograms if their cervix is abnormal or they have like a sharp bend or something's off. I'm suspicious that that may be the problem in this case because we went on to hysteroscopy. Hysteroscopy is putting a camera into the uterus from the vagina. So we put a camera in the vagina, go through the cervix and into the uterine cavity, and then we're able to see the inside of the uterine cavity. Because we're really looking with our eyes, it is the absolute best test. It catches more things than a screening test. It's actually a better diagnostic test. And so if the saline is inconclusive, if there may be something but you can't tell, or you can't get a good image inside the uterus because it's hard to advance the catheter, looking with your eyeballs is always going to be the best option. And so we want to evaluate the inside of the uterine cavity before we put an embryo inside. Those embryos are so precious and hard to get. We really want to make sure that we've done a very good test to show us that there's nothing that would decrease the chance of success with that embryo implanting. So I do have my patients undergo some form of uterine evaluation, saline sonogram or hysteroscopy, and a tubal evaluation, whether that's at surgery with laparoscopy, an HSG test, that X-ray test, or a FemView test. I'm actually a huge fan of the FemView because I can do that with saline sonogram in the office. So saline sono of the uterus, then I can push air bubbles through the fallopian tubes with the same catheter and device, see that the fallopian tubes don't have a hysterosalpingogram and that there's nothing that's going to prevent our embryo from sticking. How long is too long for a woman with no apparent risks or health conditions to wait to start having kids without adding high levels of unnecessary risk of failing to conceive or other pregnancy issues? I am 29 and considering going back to college for 3 years, but worried that waiting till I'm 32 or 33 might be too late to start trying. First of all, congrats on going back to school. You know that I love education and you can't get too much of it. The reality is every person is different. The only way you're gonna know this answer for you is to go get a fertility evaluation. We can always just do an egg count and an AMH test and evaluate your fertility so we can see if you're running out of eggs. Now, this is not a perfect test and it can change over time, but it would give you the information that if you're already running out of eggs now, you may choose to freeze your eggs to keep that option open for the future. So I have a video on egg freezing that you're able to check out and learn more about that process. To answer your question, studies show us that for most people, waiting until you're 32 to 33 to even consider freezing your eggs if you're not ready to get pregnant is totally fine. And we don't see drops in pregnancy rates until you get closer to 35 years old. Now, the important thing to ask here is what are your goals and how many kids do you want? If you want 4 children and you're not planning to start till age 35, that means you're going to be at quite an advanced reproductive age by the time you're ready for those other kids, and that may make it much harder for you. So just thinking through where you are, when you think you'll be ready, how many kids do you want, what is your goal? You know, my favorite question. That's going to help you answer this question. For most people, we say that if you're not ready to get pregnant by 32, 33, that's a good time to go get an evaluation and freeze your eggs. So current plan does not seem bad, but if you have a lot of anxiety, super easy to get that checked now and just at least feel better that at the current moment you're not running out. How many cycles after stopping birth control should your periods be regular? How many cycles should you observe to determine you are regular? And I believe you said in a previous video that your cycle should come within 1 to 2 days. Is this correct? Okay, what is a regular period? A regular period is one that comes at regular, predictable intervals within 1 to 2 days of expected. If it's flip-flopping by a week, then something may be off. Could be thyroid, prolactin, PCOS, and you should get an evaluation. When you're taking birth control pills, you are inducing a cycle or taking them solid and not having a cycle at all. But it's not a reflection of what your hormones are doing or your ovarian function. So when you stop the pill, remember that when you take the birth control pill, it tells the brain to stop sending out FSH. So if you're not sending out FSH, the ovaries are not being stimulated to grow a follicle or an egg. That's fine, but that means the ovaries have been in a suppressed or a quiet state for quite a while. When we want them to grow an egg and you stop taking the pill, they've got to wake up and the brain has to remember how to send out FSH and the ovaries have to remember how to respond. And that process can take some time. I usually say if you have not gotten a period back by 3 months, definitely you need to go get an evaluation. It can take most people around 3 to 4 months to get regular cycles again. So track them once you stop. Here's my first period. When does the next one come? If you have no period at all, call your OBGYN or a fertility doctor if it's been 3 months so you can try to figure out what's going on. Or if it's irregular, this may represent an underlying ovulation disorder that you want to get diagnosed and may want treatment for. Okay, friends, thank you so much for joining me. I would love it if you would subscribe to the channel. Remember, you can go to that community tab and type your questions in, and we will be covering them every week. You can always follow along on Instagram at Natalie Crawford MD, or listen to the As a Woman podcast for more in-depth fertility-related topics. Thanks, friends.